Hello everyone. Today we'll be talking about the normal saline. So normal saline, we are basically talking about the 0.9% NS, that is 0.9% NaCl. So it contains sodium, that is 154 milliequivalents per liter, and chloride of around 154 milliequivalents per liter. So combining 154 and 154, it gives total of around 308 milliosmoles per liter. And normal osmolality of the plasma is 285 to 295 milliosmoles. So what does it means is that the sodium chloride is slightly hypotonic when compared to the plasma. So coming to this mechanism, so we take example one by one. Suppose a patient is having a vomitings. So patient of vomiting in gastric, what is there is H plus and H chloride, that is hydrochloric acid, that is HCl. So vomiting will lead to increased loss of HCl, the increased H plus loss. That means there will be decreased H, and it will lead to metabolic alkalosis because acid is being lost. It will be alkalosis, and also chloride is being lost, and that's why it will be hypochloremic metabolic alkalosis. Now, in this patient, if we give sodium chloride, that is NaCl or 0.9% NS, chloride will replace this hypochloremia. So hypochloremia correction will happen because of this chloride. So when hypochloremia is corrected, what will happen is that now, since there is no further need of chloride, kidneys will start excreting the bicarbonate. Is basically to counteract this alkalosis. Suppose there is more loss of bicarbonate, this alkalosis will be corrected. Another important mechanism is that in patients of hypovolemia, due to any reason, maybe it will be vomitings or due to any reason, suppose patient is having hypovolemia. During hypovolemia, what will happen is there will be decreased perfusion to kidneys. When there is decreased perfusion to the kidneys, what system will get activated is it is renin, angiotensin, aldosterone system. So when this system gets activated, so increased renin will released, and this increased renin, the end product will be aldosterone. What does aldosterone does? It's aldosterone causes the increase in sodium and water reabsorption. Also, this aldosterone acts at sodium plus H plus channel. So, supposing this is the lumen and this is the tubular cell. This is the tubular cell. Now, due to increased reabsorption, what is happening in aldosterone is that sodium is getting reabsorbed from the tubular lumen to the cell and directly to the plasma here. Now, what will happen is that this happens at the rate of exchange of H plus. Now, more H plus will be there inside the lumen. This H plus will go and bind to the bicarbonate and will form H2CO3. This H2CO3 is metabolized by carbonic anhydrase into H2O plus CO2. This CO2 now again goes into the tubular lumen, and into the tubular lumen what will happen is that it will again into the tubular lumen, it is converted into H plus and HCO3. So basically what will happen is that suppose patient is in shock, this HCO3 will be also reabsorbed into the plasma and there will be decreased excretion of bicarbonate in plasma. Now, now if you give normal saline will do is what it will do the correction of hypovolemia. So you are correcting the hypovolemia. So now perfusion to the kidneys will be improved. Okay, so this will inhibit the RAS system. So RAS system gets blocked here. So there is no need for further renin, and thus there will be no need of aldosterone, and thus this sodium plus H plus channel will get ineffective. Since it gets ineffective, now H plus will remain inside the tissue and it is not going into the lumen. So all the bicarbonate which is present inside the tubular lumen will get excreted or eliminated. So thus, suppose there is alkalosis, this alkalosis will get corrected by this bicarbonate. So these are the mechanism of action of the sodium chloride. So first, it restores the chloride levels. It improves the renal bicarbonate excretion, and also since it is isotonic or slightly hypotonic, it also expands the extracellular volume and basically maintain the intravascular volume as such. It is also used. It is used as a one of the main IV fluids in fluid resuscitation. Suppose patient is in very much dehydrated, hypovolemic, or in shock. This is the first fluid which can be always preferred in those patients. Also, it can be used in severe shock or severe metabolic acidosis. So basically, the discussion always lie around that NS or RL which should be used. So always remember that in patient with severe hypovolemia or severe shock, what will happen is that your liver is also down. So due to shock, the decreased perfusion to the liver is also there. And also, since ringer lactate contains the lactate, this lactate normally is metabolized in the liver. So suppose now in give patient of severe shock, you give ringer lactate. So liver is also not functioning properly. So there will be increased lactate and it will lead to lactic acidosis. So always remember in patient with severe hypovolemia, severe shock, always prefer NS normal saline over the ringer lactate. Another advantage is that it also corrects the electrolyte imbalance. There is sodium chloride, it has hyponatremia and hypochloremia also gets corrected. It has a role in metabolic alkalosis as we have already discussed. Basically, it increases the excretion of the bicarbonate by correcting the chloride levels. Another advantage is that it is compatible with all the medications. Suppose we want to give infusion of any drugs, we want to give infusion, we can mix it with NS. It is very much compatible for it. In surgery and blood transfusion, important thing when we compare NaCl, that is NS versus RL, is that RL contains the calcium, and this calcium binds with the citrate, which is the anticoagulant in the blood, and interferes with it, whereas NS doesn't contain that's calcium, and also there is no interaction with the blood products, so safely can be given with the blood transfusions as well. Also, it can be used in the wound and surgical site irrigation. What are the potential adverse effects of NS is that one thing, it can lead to prolonged use can lead to hypernatremia. Also, it can cause hyperchloremic metabolic acidosis and fluid overload. So, suppose definitely in patients of heart failure or renal failure, you should always check and have a close watch on it because this all can cause severe acidosis in those patients. Other limitation is that it does not contain the other electrolytes like potassium, calcium, and other buffer components are not there. So, that is the limitation of it. Thank you.